You are on mute.
Yeah.
Yeah, Dr. Shobhit. Okay.
Hi. Hi, welcome to the symposium on impact of SGLT2i on cardio-renal health. And let me introduce today's speaker and the panelist. Today's speaker is Dr. Christopher Werner. He is a professor and head of the Division of Nephrology at the University Hospital of Würzburg, Germany. He has contributions to the field of cardiovascular disease, lipid disorders, and statin treatment. And Dr. Christoph has a special interest on early stages of diabetes mellitus, induced vascular and kidney damage. He is acknowledged for his work with the SGLT2 inhibitor empagliflozin, impacting cardiovascular and kidney disease outcomes. And Dr. has published more than 700 scientific papers and articles in various major journals. He was the editorial journal of renal nutrition and associate editor of the clinical journal of the American Society of Nephrology. Dr. Christoph has received the Outstanding Clinical Contributions to Nephrology Award from the ERA EDTA in 2016 and the Franz Wohlert Medal from the German Society of Nephrology in 2018. He was awarded Doctor Honoris Causa from the Charles University Prague in 2012. Presently, Dr. Werner is the president of ERA EDTA, being in office from June 2020 to 2023. Now coming to the panelists, the first panelist is Dr. Pramod Gandhi. He is a consultant endocrinologist, Kingsway Hospital, Nagpur. He is the secretary, Maha Endocrine Society of Maharashtra. He is the executive committee member of Endocrine Society of India and organizing secretary for the ASICON 2019 held at Nagpur. He is a past president of AMS 2017 to 18 at Nagpur. And he's a past president of Diabetes Association of India, Nagpur branch from 2007 to 2008. He's a regional faculty of CCMBDM, CCMDD, ESI, TYSA, and ABG Award. And doctor has conducted more than 40 phase 2 and 3 clinical trials in patients of type 2 diabetes mellitus and type 1 diabetes mellitus. Next panelist is Dr. Matthew John. Dr. Matthew John is an endocrinologist. He has extensive experience in the management of pediatric endocrine disorders, adrenal and pituitary diseases. He is keenly interested in growth hormone therapy and other forms of hormone replacement therapy. Dr. Matthew has got special training in advanced diabetes therapeutics and technology at International Diabetes Center, Minneapolis, and uses technologies like CGMS and insulin pumps. He is certified in bone densitometry by International Osteoporosis Foundation. And Dr. Matthew is involved in researching new molecules in osteoporosis, diabetes, and growth hormone insufficiency. He is a key opinion leader in scientific forums both in India and abroad. He is the current secretary of Professional Association of Clinical Endocrinology and Kerala chapter of Endocrine Society of India. The next panelist is Dr. Vipin Kumar Sethi. He is an endocrinologist and a consultant endocrinologist and HOD Care Hospitals, Banjara Hills, Hyderabad. He is a visiting faculty in IN Hyderabad. He is a life member of Endocrine Society of India, Faculty Research Society for Study of Diabetes in India. Doctor has numerous national and international publications in this credit, and he has actively participated in various international clinical trials till date. So I welcome all. Over to Dr. Christoph.
Thank you. So handing over to me, you will give me my presentation back, or?
You can start the presentation. You can share the screen, sir.
Okay, I do it again. Okay, so thank you again. A nice introduction. I have a presentation today which is more focusing on the heart and the kidney. Also, I'm speaking to prominent endocrinologists or discussing with you. And I think there are also some general practitioners and other specialists listening to this webcast. So I will walk through a special lecture today. Overall, there are cardiovascular outcome trials But we have learned over the years that SGLT2 inhibitors are not specific atherosclerotic or anti-atherosclerotic drugs. They work different, and they have more power in the heart failure area, and they have a very prominent action on kidney outcomes. So the cardiovascular outcome trials look at 3-point MACE, which is cardiovascular death, non-fatal MI, and stroke. The heart failure trial, that's clear. And the kidney is looking always on doubling of serum creatinine, end-stage kidney disease, which is dialysis or transplantation, and very, very few who refuse to go to dialysis, and then we call it death from renal disease. So these are the big trials, and the kidney is always in the secondary endpoint when we look at cardiovascular outcome trials and heart failure. But we have now also a trial, and we will get more trials where the kidney is in the primary endpoint. This is important to distinguish. So cardiovascular outcome trials is EMPA-REG outcome, canagliflozin, dapagliflozin, and recently ertugliflozin, which have, I will show you the results, produced cardiovascular outcomes and reduction of outcomes. The heart failure trial is a single trial, DAPA-HF, and EMPEROR trials with empagliflozin are coming. And the kidney outcome trial is Credence with canagliflozin, and the others are coming. When you wait 3 weeks, you will see by end of August the EMPEROR reduced results at the web. The paper will come. European Society of Cardiology will have this talk and the results by end of the month. By end of the month, in the same Congress, European Society of Cardiology, the DAPA-CKD data will be displayed. So in 3 weeks, we have more data on heart failure and kidney in the primary outcome. EMPA kidney will come in about 2 years. So here are all these baseline characteristics. When you look at these trials, you see in the first row the number of patients. The trials have a duration of 3 to 4 years. The age of the patient is virtually the same. When you collect type 2 diabetics, you will see 63 years old, 64-year-old people. More male than female, hemoglobin A1C around 8 in all trials. The diabetes duration is longer when the kidney is in the primary endpoint, and is shorter when there is less cardiovascular disease. It's important to look at the diabetes duration, and then you can see also established cardiovascular disease accumulated in these trials, and it's maximum in EMPA and minimum in VERTIS. They have a history of heart failure, not many, about 10%, and the kidney with reduced function, glomerular filtration rate below 60, accumulates differently, about a quarter, and Credence, as the kidney in the primary endpoint, has 60%, most of the patients with impaired kidney function, an area where we do not know so much. When I'm now going further, we saw recently a meta-analysis just 4 weeks ago with the major adverse cardiovascular events in the primary endpoint in EMPA-REG, CANVAS, DECLARE, and VERTIS. And there in this meta-analysis, they put also the kidney trial. You see the point estimate is left of unity. You see the confidence intervals. When they go beyond 1, you lose significance. On the other hand, you see that more or less most of the outcomes are left of unity. Important always is when you look at these slides, look at the placebo rate. And when you look at the placebo rate, you can understand the risk of the population. So you see that EMPA-REG outcome has accumulated 100% cardiovascular in cardiovascular disease in comparison to CANVAS and DECLARE. they are the less risky patients. Yeah. Credence are kidney patients, and kidney increases the risk, so it's clear it's highest. Yeah. Vertis is more or less the same than EMPA. It's always nice to look at placebo event rates to understand what patients I have in hands. Cardiovascular death was so exciting in EMPA-REG outcome, was so promising, 38%. It was less prominent in the other trials. If you do meta-analysis, the pool estimate is a 15% risk reduction of cardiovascular death. And I think it depends what people you have in hands and how some heart failure outcomes mix with cardiovascular death. Maybe this is the reason why they are differently prominent. If you look at hospitalization for heart failure, then you see a very incredible uniform picture. All the trials we do reduce heart failure and hospitalization for heart failure by around 30%. The meta-analysis, 32%. Today, we are looking always on this type of forest plots. We train our students. We are looking not always at Kaplan-Meier survival curves anymore, sometimes to see when the curves go up, but we look at the risk. And we look at the risk reduction. And over time, my students and we all get a feeling, and you also as specialists, you get a feeling if you have these point confidence intervals, how narrow they are, how far they go to unity. I think you get a very good feeling, and this is so uniform. Again, the kidney patients have the highest risk of heart failure. 25 per 1,000 patient years are at risk, and the risk is reduced prominently. That's all so astonishing with this class of drugs, what we have seen over the last 5 years. And the kidney composite also looks relatively uniform, homogeneous, and consistent. Yeah? And when I saw the EMPA-REG outcome data the first time, then I felt, my goodness, we have never seen patients not going to dialysis by about half, 50% risk reduction. If we look at credence, where the placebo rate, the risk is highest, it's not a cardiovascular outcome trial, it's a kidney trial, then still we have a 34% risk reduction. And these are hard kidney composite outcomes. In the moment, there is confusion out there about the kidney composite outcome. Every trial is different, is the criticism. Endocrinologists and especially cardiologists are coming to the nephrologists saying, you always design your trial different, why you don't have a 3-point MACE, which is uniform. So let's focus on this outcome trial. You see, the EMPA-REG had doubling of serum creatinine level as a hard endpoint, initiation of renal replacement therapy, and death from renal disease. Canvas program already was different. They went not to a doubling of serum creatinine, which is a 57% reduction in GFR. They went to a sustained 40%. And I show you a little bit of feeling about this. Declare, similar, 40% reduction. But dialysis or end-stage renal disease, end-stage kidney disease was always in the endpoint. And we look how you can compose your trials. When you do a 40% risk reduction, you blow up the number of patients. This is a simulation from EMPA-REG. EMPA-REG used 57%. But we had only very limited number of people starting from a GFR of 74 and doubling or halvening GFR. There were not many because patients were early on in their kidney career. And you see there are in the placebo group 25 patients. I remind you, it's a 2-to-1 randomization. So you can doubling 25 to 50 to understand a bit, to get a feeling, versus 16. That is a 70% risk reduction. We have no other medication. ACE inhibitors are not so potent where you can reduce it. If you go to another endpoint, for example, 40% risk reduction, you have many more patients arriving. And even at 30%, you have hundreds. But your risk is not so stable. It's lower. And this you must understand, it's still significant how these trials change the endpoint and come to different numbers of people. The hardest endpoint would be 70, doubling of serum creatinine or 57% reduction. So to understand this, we have seen dedicated cardiovascular outcome trials, first line in blue. We call them, when we look at the kidney, exploratory analysis, because it's not in the primary endpoint, it's statistically differently handled. It is a post hoc exploratory analysis, a secondary endpoint. Then we have the dedicated kidney outcome trial, Credence, and we have a heart failure trial. So let's look at EMPA-REG outcome. When you only take doubling of serum creatinine and death, you have 150 patients out of 7,000. Your risk is reduced by 46%. Confidence interval is fine. That's really surprising, too good to be true. We told the people 5 years ago. But then came the DECLARE study, the same thing. They had a similar, little bit different endpoint. You see higher numbers, but also more people, 16,000 in the trial. But the risk reduction was nearly identical. Then came the CANVAS program, a similar thing. And then we felt now we are closer to the truth. I think we can believe this. With Credence, which was the dedicated outcome trial, where the kidney was in the primary endpoint, you see the doubling of serum creatinine, end-stage kidney disease, and you have here 380 people who went to dialysis or doubled the serum creatinine. The placebo rate was 40, very high to progress, and the risk reduction was 34%. With an ACE inhibitor, we always get about 20% with this endpoint. With Credence, we got 34%. So I think we can save many, many people not to go to dialysis. And the DAPA heart failure trial was too short, was only 16 months or 18 months, 1.5 years, too short to develop kidney outcomes. You see the low number of kidney people, but the point estimate is already on the perfect side of the line. So let's compare the Renal trial, which happened in the New England Journal in the year 2000. And we used in this trial losartan. And losartan in type 2 diabetics reduced the risk of end-stage renal disease by 28% risk reduction. So when you take only this, if you compare it now with Credence, Credence has similar, a little bit higher risk reduction of 30%. But if you now look at the risk, the trial duration, 36 months, the same time, at the risk the patients have at placebo, then you see that we came down from Renal in the year 2000. The placebo risk was about 23%, left axis. And in Credence, we are better off at about 17%. Therefore, something happened over the last 20 years. Apparently, with RAS blockade, the risk was lower, and still we can go down, but still we have some remaining residual risk where we can work in the future. What do guidelines say? And I heard about that Dr. Gandhi, Dr. John, and Dr. Sethi were present and are endocrinologists, And you know the American Diabetes Association guidelines, you have your Indian guidelines. The kidney world has renal guidelines, and KDIGO are the guidelines for the kidney, and they will be published new guidelines in September. So I felt I should show you this because you may have an opinion. Of course, we look at your guidelines, at endocrinology guidelines. We feel that glycemic control is very important. RAS blockade standard of care should be applied first. And standard of care is all first, second, third, for lipid management. Lifestyle is always important, smoking, nutrition, and aspirin for secondary prevention. These are standard of care, except the first line, including an intervention, which is now the new drug on the block. The guidelines also say us that you need to do proper cardiovascular standard of care because lifetime in patients with diabetes is reduced. When they have no diabetes or diabetes and cardiovascular disease, your lifespan is reduced by 12 years. This is JAMA in the year 2015. If you now go on to 2017 Kidney International, you see in a large population that you lose 16 years of your life when you have, in addition, kidney disease. On the left side are men. When they start at young age, they lose 15 years. When women start at young age with albuminuria and diabetes, they lose 17 years. You see in black is the reference, early CKD, in blue is diabetes, and early diabetic kidney disease is the worst. And you know that some smoke, and smoking costs you also 6 years. So is it really true that if you are a 35-year-old diabetic with albuminuria, hypertension, and you are smoking, that you are losing 24 years of your life? Yes, I have seen these patients, and you also. Some are really not very good off. And the risk is highest when the glomerular filtration rate is going down from the left to the right, and especially in the low GFR, with albuminuria, urinary albumin creatinine ratio going up from micro to macro above 300 milligram per gram. The risk is very high, and low GFR and high albuminuria are independent predictors of cardiovascular mortality. Now I introduce you to my patient. I recently saw a 67-year-old male, and I did a renal biopsy because he had high albuminuria, and I found, in addition, IgA nephropathy, glomerulonephritis. Apparently, this patient has two diseases. He's a type 2 diabetic, but his type 2 diabetes was diagnosed only 4 years ago. So he has two things. He is in the chronic kidney disease stage 3 with albuminuria. This is a glomerular filtration rate of 61 and urinary albumin creatinine ratio of 1.2, which is about 1,500 milligram in 24 hours of urine collection. But we do only these spot urines in these days. His systolic blood pressure is 145/87. What do you think about this blood pressure? Not too bad, but suboptimal, I would say. His body mass index is a Western, a German patient. He has high body mass index. His LDL cholesterol is 98. Not too bad, suboptimal. Hemoglobin A1C 7.6. And his hemoglobin 11, he's a non-smoker. He told me he struggles with lifestyles, and he's saying, doctor, I have already 7 pills per day. So I was looking at these pills, and he is on treatment with ramipril already. His general practitioner has given him RAS blockade. and he is on amlodipine to treat his blood pressure, on simvastatin 20 milligram. Why he is on aspirin, I don't know. No overt cardiovascular disease so far. Metformin, he has 2 grams per day, and now I was asked, what can we do better? Should we go for a DPP-4 inhibitor or an SGLT2 inhibitor to improve his hemoglobin A1C? So he told me, I take already 7 pills, so what to do to add another drug? In Germany, we can combine some drugs. Or should I first treat the LDL cholesterol? I could switch to atorvastatin 40 milligram. It's a higher power. I could add a diuretic. A diuretic is missing. And I could drive down his systolic blood pressure a little bit more. So usually when I do this, and general practitioners and nephrologists and you endocrinologists, maybe you also focus on these things. It takes you a year. And KDIGO tells us, first of all, you should go for lifestyle therapy. Yeah, everybody, and he struggles with lifestyle. But the next step is to think, should we really focus primarily in this patients on glycemic control? Or and maybe primarily on organ protection. And this is the next word, and there is coming in now our drugs, our SGLT2 inhibitors, which are not very good anti-diabetic drugs when a glomerular filtration rate goes below 60, but they are very good organ protective drugs. So my philosophy is now I go for organ protection so we have some limitations. In the moment, the glomerular filtration rate should be above 30 to start in some parts of the world. And you can go down when your GFR drops, continue with treatment, but discontinue when dialysis is beginning. And metformin, we reduce the dose below 60 and then we stop below 30. And then if you have done this, you can do everything additional to improve glycemic control, and then you are relatively free. GLP-1 receptor agonists in countries who have sufficient amount of money and can afford are the next preferred organ protective drug if a patient has cardiovascular disease. That's the KDIGO. My philosophy now, what I also bring out for discussion is that I think we have a new we should shift the paradigm in a moment. First, to concentrate on organ protection, treat directly with GLP-1 receptor agonist or SGLT2 inhibitor according to the patient profile, and second, I optimize standard of care. Our government tells us, do your homework first, do standard of care, and then go to the expensive next strategy. Yes, expensive, but I lose time, and he has kidney disease, so I give him SGLT2 inhibitor in first line. I see a reduction in albuminuria. I see a stabilization of kidney function. And I want to see him again in 3 months, and he forgets and comes back in 6 months. So that's the real life. Second, I want to understand important clinical concerns everybody has. Usually a treatment with an ACE inhibitor or an ARB and an SGLT2 inhibitor induces an initial decline in glomerular filtration rate. And here is the figure we produced 4 years ago. You have a drop in empiric outcome by about 4 ml. And this you can see in every SGLT2 inhibitor. Every is doing the same. The mechanism appear to be the same. Thereafter, in the next weeks, the glomerular filtration rate is stabilizing. You can stop your drug after 192 weeks and bring him back 4 weeks later to the follow-up, and then you can see that your GFR is going up. Hemodynamically active drug in the kidney. and you get back what you pay at the beginning. And the difference in empiric outcome was 5 ml, was more than 1 year away from dialysis. So the mechanism are in the moment under evaluation, and a lot is known. You see the 2020 citation in nephrology dialysis transplantation. On the left-hand side, you see the action of adenosine. Adenosine comes from the macula densa and decreases the afferent arteriole, a type of vasoconstriction. But recently, other researchers in type 2 diabetes have found, in type 1, it's quite unique mechanism. In type 2, on the right side, adenosine is also involved, but adenosine has also an action on the afferent arteriole for slightly vasodilation, similar to an ACE inhibitor. And this improves the intraglomerular hemodynamics, the pressure, and the hyperfiltration is going away. So that's the mechanism. And when your afferent arteriole is narrowed or goes to vasoconstriction, you see this drop in glomerular filtration rate. So understanding this means that it is largely hemodynamic. It is reversible, but this early initial eGFR dip has raised concerns in clinical practice, as it may predispose patients to acute kidney injury. Some people are worrying. We invested the initial eGFR dip in the empiric outcome study, and here you see the placebo group. When you measure glomerular filtration rate after 4 weeks, you have also in some patients in the placebo group an initial dip. And we called the dipper those who drop by more than 10% with the kidney function. The eGFR intermediates is they are stable or a drop up to 10%. And the non-dippers, they just don't do anything or increase with the glomerular filtration rate. When you now give empagliflozin, you have more patients who decline with the glomerular filtration rate. So it's doubling. And then we were interesting how these 3 curves are looking and how many patients are also who dip more than 10%. And we found participants 1.4% with empagliflozin and 0.9% with placebo who dipped more than 30%. So if you are living in a large Indian city, I heard Hyderabad, then you have a town with millions of people in front of you. And if you give to 5,000 empagliflozin, you will see in the hospital some patients, 1%, who dip more than 30%, if you measure it. Yeah? And we have seen patients who dip with about 60 ml, and this could be seen as acute kidney injury. Also, 4 weeks later, your GFR goes up again. Just tell you, a minority, 1%, and also on placebo. Glomerular filtration rate is something not very precise sometimes. And if you look at the time curves over time, you see the dippers on the bottom. They start with a lower glomerular filtration rate. They go down to 58, 60, but then at week 12, they are up again. So meanwhile, I have seen so many patients also in the EMPACT kidney study, 150 in Würzburg, I put on SGLT2 inhibitor and empagliflozin, and we do not measure creatinine after 1 week or 4 weeks. I just wait, and then I don't see the dip. I'm confident from all trials, 30,000 patients, that it is stabilizing after a certain point of time. However, there is controversy out there and there are other opinions. So if you look at the change in GFR from baseline to last measurement, in the dippers, non-dippers, or intermediates, then you see that all go up in the follow-up, whereas the placebo patient, they stay down whether you dip or not dip. So that's the same pattern in all patients, very uniform. So can you predict a dip? When you have more than 10% with EMPA, and the risk is when you have diuretic use or have a higher KDIGO category, then you can predict it. And the overall population has an odds ratio of 2.7. If you look by diuretic therapy or by KDIGO high risk, so more albuminuria or less glomerular filtration rate, you see that the risk can go up very high when you give in addition to a diuretic therapy. And the real world studies, they show us that when doctors start with empagliflozin, they sometimes slightly reduce the diuretic treatment. Also in the trials was not done. But apparently these data, they reduce the extent of the dip. So the classification of CKD is in the heat map of KDIGO. You see on the left-hand side the glomerular filtration rate stages from 90 GFR down to 15. Above you have the albuminuria categories from no albuminuria to micro to macro albuminuria above 300 UACR, and the risk is increasing. Those who really are at very high risk are here at the bottom. They are on the slope to dialysis. And in this range, 15 to 29, we have not a lot of knowledge what we can do with SGLT2 inhibitors. But in 3 weeks, the DAPA-CKD study enrolled patients above a GFR of 25, and they will show us the results in the low glomerular filtration rate category and what we can do at the lower end. The future is in kidney disease. The trials are coming. We have seen Credence. The Credence population was a glomerular filtration rate 30 to 90. This is a population usually endocrinologists see and nephrologists do not see in Germany. And Credence people have had albuminuria, had to have above 300 milligram per gram. The DAPA-CKD study, which is now coming up in 3 weeks, included patients with 25 to 75 ml and lower albuminuria. So would be interesting. And the EMPA kidney study, which is ongoing, enrolls a broad spectrum starting from a GFR of 20 to 45 with no albuminuria. And those with higher GFR had to have albuminuria that we can pick the hyperfiltering people. So this is the data you want to see in the next years. You are maybe very confident to treat normal kidney function, cardiovascular disease, a little bit of albuminuria, but we have so many questions in the lower glomerular filtration rate area. So here are the 3 trials, and I think I'm coming to the end. And thank you for the attention, and we'll wait for your questions or look at the chat. Thank you.
Thank you, Dr. Christoph, for such a wonderful presentation. So I'll be taking the question from the audiences. First question, Dr. Sethi. The audience has asked safety of empagliflozin in elderly age more than 75 years, medical legally normal renal function.
I think it is not to do with the age. It is also to do with what is the person's renal status, what is his cardiac status. His age at one point of time was a contraindication on account of rarity, because if people fall, they may fracture. And there was some association of fractures with one particular SGLT inhibitor in one study, not repeated in the second study. So these are the individuals who are more prone for heart failure. These are the individuals who are likely to have kidney disease, decreased GFR, on account of age-related and disease-related issues with the kidney. I don't think age in itself should be a factor that should be denying therapy to the population who otherwise is to receive. The usual precautions are obtained. If somebody has got benign prostatic hypertrophy, that person should be told that the urinary volume is likely to increase, the frequency might increase, and if they can tolerate it without having genital mycosis, then I think the benefits far outweigh the slight increase in the urinary frequency, even with benign prostatic hypertrophy.
I agree, actually. Thank you. Very good response. Yes. And meanwhile, in EMPA-REG outcome, we have looked at the subgroup of 500 people with more than age 75, and we saw the same result and no big risk.
Next question, Dr. John. There is a question that what is the use of empagliflozin in patient with urethric stone?
Urethric stones.
Yes, yes.
Urinary stones, see, generally as a rule, we don't use people who have urinary stones and they are having a recurrent urinary infections. We usually don't prefer to use SGLT2 inhibitors. But as such, if you look at the effect of SGLT2 inhibitors in terms of uric acid stones, I think there are ongoing studies of data looking for a reduction in stones, and that has been shown in smaller trials. But I think there is ongoing data in studies being done, especially with dapagliflozin in terms of reducing the incidence of uric acid stones. But if there is no other someone just having stones without the history of infections, I think there should not be any contraindication in using any SGLT2 inhibitor. That's what I feel.
So next question is there any added benefit obtained if empagliflozin is mixed with ARNI in case of heparin in ETDM patient? Dr. Pramod? Dr. John, can you put a light on this? Is there any added benefit with empagliflozin if it mixed with ARNI in case of heparin in T2DM patients?
I do not know whether anybody can answer these questions. I have seen data from the Emperor reduced trial, which will come out in 3 weeks. And this is the most recent trial, which has already now accumulated ARNI treatment in heart failure patients. The DAPA-HF had very few ARNI patients. The Emperor reduced have about 16% ARNI patient, but still 16% is too small to really see an added benefit. I would say most likely yes, and because different mechanisms really cannot be very, very sure.
Can I ask one question to Professor Christopher Wanner? Shavik, is it okay?
Yeah, please, sir.
Yeah. What do you think will be the sort of results which will come out in EMPA kidney, especially in the patient group without albuminuria? What is your prediction?
The effect is less because these non-albuminuric patients, there are many which are not so progressive. Some are progressive. But if you look at the entire mix of patients, we assume that the effect is less prominent, and therefore we increase the number of patients in the EMPA kidney study to 6,000, that we can see what you are asking. So
I think that that particular area remains a sort of unanswered thing. If we are looking primarily at the hemodynamic-based effects of SGLT2 inhibitors, I think that area becomes very important in terms of therapy. With at least some areas showing that the non-albuminuric renal diabetic kidney disease is a sizable volume of patients that you see in the outpatient department, the ones without albuminuria. So that becomes a very important area. That's why I asked that specifically. Thank you. Thank you for the answer.
There's a question, Dr. Sethi, that what about the LV mass index reduction with EMPA?
LV mass index?
Index reduction with empagliflozin.
These are good surrogate markers or to show mechanistic results, and there is some positive data in that. What is more exciting are the top-line results of the EMPA heart, which already tends to show that there is a benefit even at lower GFR. So, as was detailed by Dr. Christopher, we are extending the usage of SGLT2 inhibitors for organ protection, irrespective of and notwithstanding the glycemic control. So, there is a place for using these drugs, even if the glycemic control is good or HbA1c is on target, either by adding these drugs or by substituting these drugs. So we are now also, the only limitation so far has been the GFR, but the GFR for DAPA heart was about 25, and the GFR for Emperor reduced is also about 20. And the studies which are coming for the kidney, starting with Credence, which brought down the GFR to 30, now the DAPA kidney again going to about 20-25, and the empagliflozin study, which Professor alluded to, bringing it down to 20. So I think the organ protection, because it's not on account of glycemic efficacy, is going to stay, despite the fact that the glycemic efficacy of these drugs is close to 0.2, 0.3% at lower GFR. So there's a difference in approach now towards organ protection, independent of and irrespective of glycemia. So these drugs will be add-ons. For instance, as he pointed out, ACE inhibitors do really nothing, ARBs don't do anything much of glycemic control, yet they are very good drugs for renal protection, as would be probably Findernon one day. So we are not looking at glycemic control when we are using this, because the point that's often used and stated is that these drugs are not good anti-hyperglycemic agents at that GFR, but that's not what we're using them for at that point of time.
Can I have one more question to Professor Banner? The data that you showed in terms of dipper versus non-dipper in terms of EGFR, was it a subgroup analysis of EMBARRAGE outcome study?
Yes, post-hoc subgroup analysis, yes.
Okay.
But we did not break the randomization, so we stayed in the randomization. So it is exploratory post-hoc, interesting to see how patients behave, yeah.
So it was actually irrespective of whether they received empagliflozin or the placebo, you were looking at dippers versus non-dippers. Was that the way it was done?
Yes, yes.
Okay, that's nice. Another thing I wanted to ask you is that there are a group of patients who would develop hyperkalemia quite fast when you start them on RAS inhibitors, albuminuric people. At the smallest dose of RAS inhibitors, they move into hyperkalemia. So are these group good candidates for use of SGLT2 inhibitors because of the albuminuria part?
Yes, they will respond in a similar way. Very good candidates, yeah. I understand. Usually I increase the dose of diuretic, but if you do diuretic dose increase and SGLT2, maybe it's too much. Yes, I would say, yeah, 20% in EMPA-REG had no ACE inhibitor and it worked in the similar way. So good candidates, yes.
Yeah, sure.
Okay, there is a question, Dr. Thomas. Sometimes SGLT2i causes severe overdiuresis. How do we manage the hemodynamics, especially in patients with coexisting congestive heart failure beyond stopping diuretics? That's a question, Dr. Mohan.
Yeah, means you mean heart failure patients?
Sometimes SGLT2 inhibitors causes severe overdiuresis. How do we manage the patients? How do we manage the hemodynamics, especially in patients with coexisting congestive heart failure beyond stopping diuretics?
I'm very sorry. I think that's not my area. I think Professor Vanna can probably.
Yeah, Professor Vanna, yes.
In the randomized trials, we have not seen this signal. However, I heard these questions often that doctors observe hyperdiuresis or overdiuresis. Usually, it is about 200 to 300 ml per day, and this is something the patients do not experience. So what are the patients who have half a liter or a liter? Are they overhydrated? I could not figure this out so far. I would just continue if there are no other symptoms. If you have low blood pressure or hypotension or vertigo, then maybe you stop intermittently and start again. But it should set a new level after some days. Yeah.
One more question to Professor Vanna. The EMPOWER outcome study and the VERTIS CV has had almost the same group of patients getting randomized. The event rates also looked similar in the placebo arm. Why is it that VERTIS CV did not show the sort of benefit that empagliflozin showed? What are your sort of postulates on this particular aspect?
So I have asked myself, very prominent other people, nobody has an explanation. But I have seen over the many years in trials one phenomenon. VERTIS started to recruit 4,000 patients. And then when they were in, after they have recruited, they saw the result of EMPA-REC, and the VERTIS study group felt that they can do the same, and by putting another 3,000 patients on top. And then they started to recruit the other 3,000. So actually, I do not know whether these are two trials like the CANVAS and the CANVAS-R, whether you have seen different results. I did not get the answer, but I got the answer. Yes, we have 4,000, and then we continued. And maybe the second 3,000 are different patients than the first 4,000 when the sites are activated again and they continue. And I would like to see this data, how the second study number 1 and 2, but the VERTIS people say you cannot say study number 1 and 2. Yeah, don't do this. Yeah, yeah. So that's my hypothesis. And in trials, sometimes some things happen when you have really different people. Also, the entire, as you say, the entire group has a placebo risk, which is nearly identical to EMPA-REC outcome. Yeah.
Is there any information on the relative potencies of these drugs in terms of urinary glucose excretion? Means I'm just trying to find out why this happened. That is why I'm very interested.
Yeah, class effect or no class effect. And if you now look at this specific molecule, how it is compared, specificity compared with empagliflozin, you nearly find similar thing. EMPA is a little bit more specific, but VERTIS is ertugliflozin is already quite good. You cannot explain by this data that there should be a difference. Yeah.
Thank you.
Yeah. Dr. Sethi, there is a question that is there any safety of empagliflozin in COVID-19 positive asymptomatic patient?
Yeah, I can do this because about a year ago, when I was sitting with endocrinologists together, we were discussing the sick day rule. Yeah. To avoid diabetic ketoacidosis, and it was explained to me how to handle these patients. And now comes COVID, and the AstraZeneca company is doing a COVID-19 trial with DAPA, and I don't understand this. It goes against the sick day rule. So I don't know, maybe this is a very good marketing study to say, hello, we are active here and we test a hypothesis and mechanism. But I think you could continue to treat, depends on the severity of the COVID infection.
And they have called it DARE, I think. I think a great name for a trial doing that.
Yeah, yes.
Oh, really? I didn't know. Okay.
Its short form is DARE. So
There is a question that, is there any direct beneficial effects of empagliflozin on rectal dysfunction?
I do not know this.
That's question, actually.
Dr. Gandhi, John, or Stacey, do you know this?
I think one is that certain factors, including vascular reactivity, has been shown to be improved by SGLT2 inhibitors. There is one DAPA study on that. I think this thing has come out from I remember seeing a poster, I think a year back or something, from one of the authors from India who has put up showing that people who were on SGLT2 inhibitors had an improvement in erectile dysfunction. But this was not a sort of randomized study. This was just a observational study in people taking. So it's not controlled for the A1C reduction or for improvement in other parameters. Things like those were not controlled during the study. So just an observational study. I also don't know the exact answer. I don't think any of the CVOTs looked into that particular aspect of it.
Dr. Sethi, there is another question. Is there any evidence of MRA with SGLT2 in heart failure? Is there any evidence of MRA with SGLT2 in heart failure? Mineral cardiac receptor antagonists.
I think the studies which were done did have some population which were receiving ACE inhibition as also diuretic. They were not subclassified. If I don't know who were receiving the mineralocorticoid receptor antagonists. I don't think that there was an impact because various parameters were studied. Unlike in the Canvas study where they had some relationship with diuretic use and beta blocker use for some beneficial effect, I don't think there was any difference between background mineralocorticoid use versus no mineralocorticoid use. Maybe Dr. Christopher can show some light on that because I don't think that there was a difference and there were some people who were receiving this.
In EMPA-REG outcome, we had 6% with MRA. 6% is not much. However, we were looking into this and we did not find a difference.
Okay. There is another question, sir. Is SGLT2 inhibitor safe in low eGFR? So what is the question?
Yes, the American Food and Drug Administration gave now an indication on the basis of the Credence trial to start treatment above eGFR of 30 and stop when patients go in dialysis. So you can treat them during lower stages, lower GFR, and there is no sign that safety is not guaranteed. So it's you can do this, yeah? But you cannot start in the moment at this low range. I find it sometimes a little bit dangerous. If you go to the United States nephrologists say, oh, a healthy start of dialysis is a glomerular filtration rate of 15. When you now start an SGLT2 inhibitor at eGFR of 20 and you have this dip and you fall at 14 and you change your doctor, oh my goodness, you are in dialysis. Yeah? So you need to know what you are doing. Maybe not in India, but.
Okay, so I think so. There is a last question. The last question is the incidence of prostatitis in patients on empagliflozin. Incidence of prostatitis in patients on
Prostatitis?
Yeah, prostatitis. That is.
I think by and large, urinary tract infections are not increased in incidence in individuals who are on SGLT2 inhibitors. And prostatitis also, I don't think is anywhere different in individuals who are using SGLT2 inhibitors, whether AMPA or any other missing.
Also, somebody has questioned that can empagliflozin can be applied in non-diabetic isolated HF patient?
Yes, the DAPA heart HF study, heart failure, has included non-diabetic heart failure patients. The Emperor Reduce study will show data, and they already say that there is no hypoglycemia in non-diabetic patients when you give them dapagliflozin or maybe empagliflozin. So yes, you can. Heart reduced diastolic function. The big study DAPA preserved, which EMPA preserved, and also with DAPA, where you have the diastolic dysfunction, will come in 1 year. And this would be exciting. We have no drugs for diastolic dysfunction and heart failure. So, but everybody is expecting positive results.
So we are done with the questions. We are running on time. And just I want to say thank you to Dr. Christoph for this wonderful presentation. And thank you, Dr. John, Dr. Sethi, Dr. Pramod, for monitoring this session. And hope to see you in the future.
Thank you.
Thank you very much.
Thank you.
Bye-bye.
So thank you all. I'm ending the meeting now. Thank you.